Welcome to Cardiac Surgery Simplified, a series where we discuss interesting cases and highlight key moments during surgical procedures. Presented by the Frankel Cardiovascular Center.
We present the case of a complex endocarditis patient. This is a 57-year-old female with a history of hepatitis C and intravenous drug use. She presented to an outside hospital with bacteremia, an acute intracranial hemorrhage, and an acute stroke with unilateral paresis. At that hospital, she received medical therapy and was discharged to an LTAC with intravenous antibiotics and rehab. 1 month later, she presented to our hospital with acute cardiogenic respiratory failure and severe mitral regurgitation. She met criteria for mitral valve surgery. This was done through a minimally invasive approach. Our first step was to confirm the lesion upon valve inspection. Next, we place our annular sutures to optimally expose the valve. Once we confirm the lesion, we perform the triangular resection and then close this primarily. Next, we size the annulus with a flexible band. We decided to use a flexible band so we can customize the band to the patient's anatomy and alter to the AP diameter. This is the intraoperative TEE, showing a prolapse of P3 as well as a second jet due to a perforation of the P3 component of the valve. Once we expose the valve, we identify the area of interest. You can see a vegetation as well as a perforation of the P3 segment. Our next step is to place annular sutures to optimally expose the valve. Here we use interrupted 2O ethibond sutures for this. We then test the valve and confirm the lesion is located just at P3. As you can see, there's a prolapsing segment with vegetation on it as well as a perforation. We remove the devitalized tissue by performing a triangular resection, starting from within the perforation and excising all the affected tissue. Fortunately, with redundant tissue, we were able to close this primarily using a running 4O ethibond suture. We are careful to imbricate the edges to create a smooth surface of coaptation. Repeat valve testing already is showing that the AP diameter is different along the size of the valve, but you can see that there is a residual leak medially. We do place an additional suture, additional 4O ethibond to advance the commissure to try to help with this. Repeat valve testing is done and shows that residual leak has improved. We now size the annulus, and we do what we call a functional measurement or functional valve sizing, where we're filling the ventricle, in this case with del nido cardioplegia, and true size to the entire annulus with the ventricle full. Here we are going to select a flexible 32 millimeter band, and we will intentionally tailor this band to optimize the anatomy. You can see upon retesting before we secure the ring that there is still a leak medially, and we'll want to optimize that. So on the lateral side, we keep the shaper on to make sure we don't downsize the ring too much. The patient had a small coaptation to septal length of less than 2.1 centimeters. We confirm the downsizing. We're going to intentionally downsize the ring more medially by taking the shaper off and then securing more tightly to close the AP diameter. In this way, we're able to tailor the anatomy of the ring or band to the patient. You can see this asymmetric band allows for optimal coaptation. There's no residual mitral regurgitation on postoperative transesophageal or transthoracic echo. The patient recovered well and was ready for discharge on postoperative day number 4. She was ambulating the halls with the help of physical therapy and had a complete resolution of heart failure. She was discharged to a rehabilitation facility with 6 weeks of intravenous antibiotics. Thank you very much.